there's a number of people who have been involved in this. It's quite a large team, so I want to make sure everybody gets credit for it. Only a small piece of this work is really mine, and actually Amir, sitting here as well, has been doing the economics component. But we have a large team of people at OCRC who are doing all of the epidemiological component of it. And then a couple of other people, Hugh Davies from UBC and Thomas Tinkates from Ryerson. So it's a large team. The silica dust part of it is just one of several exposures that we're looking at in this initiative. We're also looking at asbestos, I believe skin cancer from UV exposure, and is there any other one? We're doing diesel fuel exhaust. Yes, that's it. So and it actually carries on from a look at the economic burden of various occupational cancer exposure, carcinogen type exposures. And this part of it is taking it to the next stage where we're actually doing cost benefit type analyses, looking at best practice initiatives and the benefits and the costs associated with them. So just an overview of the presentation. I'll cover a number of different items, really summarizing with some of the break-even analysis that we've been doing with the costing of both the benefits and the costing of the intervention. It has a lot of pieces to it, and I'm going to try to describe each of those pieces in stages. Hopefully they'll fit together nicely. There's some parts that aren't well formulated all the time. We're making a lot of assumptions about some of the future expectations in the construction sector here in Ontario, in terms of the population size, best practices that are already currently in practice, and the level of uptake of those best practices, and then some incremental analysis of what we'd expect to see if we did it across the board. So you might have some thoughts about some of the assumptions that we're making, and I'd love to have a discussion afterwards about that, because some of them are obviously tenuous. We're looking from 2030 to 2060 here in Ontario, so projecting quite a long period of time, 30 or 40 years of activity in the construction sector. So invariably, we've had to make lots of assumptions, and some of them you might question. We question them ourselves, so it'd be really good to get some of your feedback on that. But hopefully some of those pieces will come together reasonably well by the end of the presentation. There's more than 4 pieces, actually, so that's an understatement there. Okay. So just a bit of background is the first piece and the objectives. So just a little bit about silica dust. I'm not sure if any of you are familiar with the construction sector and silica dust is. Raise your hands maybe if some of you have had some exposure to silica dust in that way. Okay, so I'm new to it myself too. So some of this was new to me when I started on this project with our team. So it's actually one of the most common minerals on Earth. And it's a basic component of all kinds of common, terrestrial things, soil, sand, and rock. It's used in foundry casting, cement, abrasive, sandblasting, hydraulic fracturing, ceramics, metal production, water filtration. So you come across it in all kinds of activity. And the inhalation of this dust is obviously associated with lung cancer, and that's what the big issue is, and that's what we're looking at, best practices around prevention of exposures to silica dust and reduction, trying to avert some of those lung cancer cases. There's approximately 380,000 Canadians who are exposed to it at work, primarily in the construction sector. Exposure concerns arise when the product containing the silica dust are disturbed. So when there's some kind of grinding or cutting, drilling, or that kind of chipping. You probably see it a lot on the street when you walk around in Toronto. There's lots of construction going on. And that kind of thing is quite common in construction sites. And that background picture you can see there, you've probably seen those kinds of scenes. I always check out to see if people are wearing masks. And I've just gotten into the habit of it now, working in the occupational health and safety field. And I've never stopped anybody and told them to put on their mask, but maybe I should. Some more data about it, workers who are exposed in it by region. As you can see, Ontario, obviously being one of the most populated provinces, also has the most number of people exposed to it. If you see up, let me see if I can get there. Up here, you can see 140,000 people in Ontario exposed to silica dust. Here are the kinds of activities where it happens, and most of them are in the construction sector. And that's the website where I've got these statistics. They're quite recent. I think they're probably like 2016, 2017. So, some more details about attributable lung cancer cases in Ontario. About 200 cases annually. Half of them are in the construction sector, about 51%. This is a breakdown by the various industries. 87,000 people exposed in the construction sector, about 100 lung cancer cases a year associated with silica dust exposure in Ontario. So next, I'm going to turn on to the intervention options. Some of you may know this hierarchy of controls. I'm new to it as well. I'm not an FE person, but elimination obviously would be the most desired approach, not always possible. Substitution would be another possibility. Engineering controls is what we're actually going to focus on. One of the options we're looking at is called the wet method, which is considered an engineering control. Administrative control, people do their work, so protective equipment, and that's one of the other strategies we're looking at, wearing masks while you're doing cutting of things that have lots of dust. So here are the three intervention options that we first considered when we went down this path of doing this study. And we had long discussions with people in the construction sector here in Ontario. Some of our colleagues reached out to a number of people in the field to get a sense of what they felt would be most realistic to propose going forward. The wet method was one of them. As you can see, the before-after kind of scenario. When you don't wet it, there's lots of dust. When you wet down whatever you're cutting, there's much less dust. Personal protective equipment, that's like a half mask that you're wearing. You're not wearing eye protection, but you're just wearing the mask or the part that's around your mouth so that, you know, when you're breathing in, there's filters that take out the dust. Another possibility is local exhaust ventilation. I'm not sure if you can see it back there, but there's a hose attached to this equipment. A lot of equipment does come with that kind of hose attachment where you can have a suction in it, you know, attach it to a motor that sucks out the dust as much as possible. You can see there's still probably I'm not sure if you can see it in the back, but there's a bit of dust still. This person's also wearing a mask. So this person's actually using two approaches, you know, to really protect himself from that dust exposure. We focused on the wet method and personal protective equipment, and that's what we're going to look at going forward in terms of best practices over the 2030 to 2060 time period. What would be the cost of those best practices and what would be the benefits? We're not looking at local exhaust ventilation. It was felt that this just wasn't realistic across the board in the construction sector. Exhaust ventilation can take different forms as well. You can sometimes set up a room that has an exhaust system as well, where you're doing the cutting, so separated out from the rest of the work site. There's various permutations of it. Sometimes it can be quite expensive, and that was one of the reasons why people felt that it wasn't possible to go forward, at least at this time, with with comprehensive local exhaust ventilation initiative. So we're focusing on wet method and personal protective equipment, specifically the half masks. So the research question, and it's a big one. I'm trying to get everything into the question here. So assuming implementation of best practices, the wet method or the half mask for silica dust exposure reduction in Ontario in the construction sector for the period from 2020 to 2060, when would the monetized benefits, so we're looking at monetizing the averted cancer cases, when would the monetized benefits equal or exceed the intervention cost? You know, we often think of that point where the benefits equal the cost as the break-even point, and at a certain point into the future, you exceed that break-even point, and then there's a net benefit. So we're looking over that whole time period. At the front end, we would expect to maybe not see the benefits be equal to the cost because these are long latency conditions, and it takes time before we actually realize averted cases associated with these prevention measures. That's why we're looking at such a long time period, over a 30, 40-year time period, because it takes a bit of time before the benefits get realized. So the analysis components that we have, so we're going to identify the number of workers exposed to silica dust for 2030 to 2060 time period. So it's quite a projection. And I can't speak to too many of the details about that, so don't ask about it. But we did do, that was a big front-end part of our project. Our colleagues at OCRC focused on that part. There are people doing this kind of stuff in the government as well. We did start off with, I think, a Statistics Canada model that did some preliminary projections various sectors up until 2040, and then we extended that and embellished on it and focused on this kinds of construction occupations that we really need to think about that are affected by silica dust. We're going to estimate the future lung cancer burden due to silica dust exposure under the current practices. So we're assuming the status quo at the front end. If we continue to do what we do currently, what would be the number of cases you'd expect to see over that time period that we're projecting up to 2060? And then we would think about the calculating cancer cases prevented with each of the methods. So, the reduction in exposures results in down the road averted cases. And then we're going to monetize those benefits of something that we actually did in an earlier project that we draw on for the purpose of this study. Estimate incremental costs as well. So how much would it cost construction sector to equip everybody with either those half masks to be used whenever they're working on activities that result in silica dust exposure, or using the wet method in cases where that is feasible. And it's not feasible in all scenarios. Only a subset of people exposed to silica dust could use the wet method. And I have a question.
I have a question. I think it's a clarification.
Sure.
Do we have any data on how effective is the wet method in terms of reducing silica, air silica levels?
That is a really good question, but it's not a question for clarification. It's a question for our discussion, and I will throw it back to you and the rest of the audience to come up with some kind of ideas of how best to actually build that into our modeling. That is one of the things we've been struggling with in terms of understanding what to expect in terms of, if you implement them, what would be the reductions in exposures and the number of averted cases. It's all woven in, and I'll point out the places where you might think about that puzzle and formulating in a better way some of our assumptions. But thank you for asking that. Okay, so estimating the incremental cost of the wet method and the PPE separately, and then identifying that break-even point. And actually, we projected over the entire time period, even beyond the break-even point for this purpose. Everybody with me? And am I loud and clear so far? I hope. Okay.
No comments from
Okay, I've been warned there's about 4 microphones here that I have to be conscious of not moving too far away from them. Estimating and valuing the averted cases. So this is the part that our colleagues at OCRC focused on, and I can speak to it only lightly. I'm not an epidemiologist, but there's a lot of equations here too. Bear with me, there is no equations in the economics part of it. Okay, the production of a disease caused by a specific exposure is what we would define as the attributable fraction. An example would be that 4% of lung cancer cases among men are caused by occupational silica dust exposure. So that's where we want to get to with the epi stuff, is how many of the cases, there's registries for lung cancer, how many of those cases can we attribute to the exposures that happen in Ontario construction sector that are attributable to the silica dust exposure. In the absence of the exposure, obviously the disease would be prevented. So, we're saying that these cases, the ones we attribute to the exposure, could be prevented given best practices, wearing PPE or masks, or using a wet method, or some other exposure reduction efforts. There's an equation there for attributable fraction. Don't ask me to explain it. And then here is just a diagram of the risk exposure period that we're looking at. Say our first cases of averted cases of cancer happened in 2030. So we're looking back over a 30-40 year period of exposure, because it does actually take that long for some cases to arise. So we are really starting early on in the late 20th century to look at how many people were exposed, working in the construction sector, likely exposed to silica dust. Follow up them along in time-wise in our stylized model up until 2030 to see how many of those cases we can attribute to silica dust exposure. This is the relative risk curve. It's a pooled analysis of 10 studies. Another equation that I'm not going to explain. But one of the main things I want to point out, as you can see the curve here, this is a sort of cumulative exposure, and this is the relative risk. It's very flat at the far end, so it's very early on in terms of the lifetime exposures really increases your levels of getting lung cancer quite substantially. But once extensive exposure has occurred over your lifetime, it it's relatively very little difference in terms of the relative risk of getting lung cancer kind of thing. So low levels of exposure, I guess low relative to the whole curve that we're looking at, are quite significant in terms of increases in probability of getting lung cancer. More details on how we went about identifying these details about relative risk and attributable fraction. We're looking at employment data over quite a long period of time in conjunction with some information from CARES Canada on the job exposure matrix. There's an exposed population by age distribution, tenure in the construction sector, their survival probabilities, and continued working in the construction sector. A literature review where we gathered some relevant information on relative risk. And then there's a probability of exposure, and the relative risk with the probability of exposure then gives us our attributable fraction. So that's just the background information on how we get to that attributable fraction that feeds into our assessment of how many cases of lung cancer that we're projecting will occur in the future. Given the status quo, we can attribute to silica dust exposure in the construction sector. You with me, Sal? Okay, good. Okay, so a simple graph, but the number of silica exposed workers. So this is the baseline of people working in the construction sector who are exposed to silica dust in Ontario. As you can see, we start off with just under 100,000 workers in 2030, and by 2060, we're projecting that sector to grow, by about 25%. Linda?
Your previous slide, it had ever exposed, right? So are we, is this showing, so even one day, you would be in the ever exposed?
I'm guessing if you're working in the construction sector, you'd be exposed more than just one day if you're working in an occupation that works with that kind of material. But there people do come in and out of the construction sector. Maybe they work for it a year or two. They did include that changeover in terms of staffing within the sector and people not being in their whole careers. There's a number of underlying assumptions that they're trying to create a longitudinal profile of the probability of continuing to work in the construction sector, so that we can count how many new people who are newly exposed versus long-standing people working in the sector who are exposed. There's a lot of detail that went into that part of the projections that brought us to this.
So, and what are the criteria we used to do this projection? And why would it increase rather than decrease?
Okay, well, this is my baseline understanding would be that the construction sector would be growing over this time period as the economy grows, as the population grows, as the sector gets bigger, and so that there are more people. Pardon?
There must have been a set of criteria applied and why would the economy grow, especially in the construction sector? I guess I'm questioning the assumption.
Yeah, for sure. No, that's good. I'm glad you are. As I mentioned, we did have some projections of some modeling projections that were already done by another group. I think it was Statistics Canada, and we added to that. So they went up to 2040, or I believe, or something like that, and we were projecting up to 2060. I don't think it's unreasonable to think that our economy will grow, even if nominally. Construction has been, we look outside, it's been exploding. I'm not sure how much it'll continue at that pace, but my sense is that the bulk of this growth in exposure is due to the sector growing. And remember, this is baseline, so we're assuming the status quo. So it's not like there's going to be more exposure per person working in the sector. It's just more people, and that's why there's more people being exposed. So this is assuming that we're not going to have any changes in practices. Whatever we see out there currently, that's what people will continue to do. In terms of certain fraction might be wearing masks, but not everybody. Some people might be doing the wet method or some other engineering controls, but not very many people. So we're assuming that. And so we're just taking that into the future kind of projections to 2060 as a starting point, because then we want to see about how many cases we'd expect to avert due to best practices being implemented across the board. Okay. So this is the attributable cases by target year from 2030 to 2060. So these are our assessments of the baseline based on current activity in terms of best practices. You know, very small fraction of people using masks, a small fraction of people using the wet method. And it's based on the number of exposed people and all of that messy attributable fraction and relative risks that we calculated at the front end. And so we start off with 107. Remember, one of our earlier slides, we said there was about 100 people even today that are have lung cancer in the construction sector on a yearly basis. It grows to 181, mostly, as I said, as a result of the sector growth. And then this purple that we see is what we would expect to see from full elimination of exposure. So if we could stop the exposures completely starting in 2030 and didn't have anybody being exposed to silica dust right up through to 2050, we stopped the exposure of time period 10 years before, we'd expect to see only 81 people, lung cancer cases in 2060. So as you can see, that gap between the blue and the purple is the difference from current practices versus complete elimination. And there's still some cases, because even if we eliminated the exposures for that entire time period, there are people who were exposed before 2030 who would get lung cancer later on in this time period that we're looking at. So the 81 cases and all the other ones that we see are from exposures that happened prior to our hypothetical, best practices implementation in this sector. So we couldn't completely eliminate lung cancer because this historical exposures are still there, and they take a long time to manifest. So intervention benefits. So the benefits of exposure reduction are the number of cases that we averted. So that gap between the status quo versus complete elimination would be one possible scenario. There's obviously other possible scenarios of different levels of exposure. The monetary value of preventing a case we took from a study that we had done for across Canada on lung cancer due to occupational exposures from asbestos and silica dust and various other lung cancer carcinogens. We considered for the case costing the lifetime cost of a lung cancer case. So from day of diagnosis to whatever life expectancy they might have following that diagnosis, we followed them a hypothetical case to cost out health care, lost productivity, lost health-related quality of life, all of the stakeholder kind of implications of having to address being a case, whether it's the family, whether it's the healthcare system, whether it's the employer, kind of thing. And I'll give a bit more details in the next slide. So it included a really broad category of cost, the healthcare costs, I mentioned productivity, health-related quality of life, or maybe the three big buckets that we looked at, but there was lots of detail there as well.
Yeah, there's a question online. It's just about the linear growth. Are you anticipating that there would be a 30-year linear growth? Question.
A linear growth in the number?
I guess
of
is
cases.
it in the number of cases or in the industry's growth?
Do you want me to go back that one? If we can assume that the construction sector is growing in terms of the size of the workforce in that sector, I would say that there would be a growth in the number of cases based on current practices. Just we're going to expect to see the same attributable fractions and relative risks as we have seen in the past continue with a larger population. So I'd expect to see the number of cases to rise. I hope that answers it. Okay. So for the case costing, which is actually ultimately going to be our benefits, if we avert those cases, they'll be our benefits of that intervention. Or we want to really take a societal level perspective, because these costs of someone getting cancer, the individual obviously themselves has cost implications and quality of life implications, but the family, the employer, society does. So we want to capture all of those costs when we're doing this case costing. So this is maybe just a schema of some of the categories we considered: the individual, family, employer, systems level. We aggregated that up all the way to the societal level to capture all of those individual cost components as a total summary. Direct costs could be out-of-pocket health care. It could be informal caregiving from the family. Employer may pay some insurance programs. There's a healthcare systems cost as well. The indirect cost, that's a vocabulary often used to describe the productivity category, which considered indirect because it's not directly about your health, but it's as a result of your health, you're unable to continue in your occupational role or doing other social role engagements, home production as well. So we considered home production, we considered activities in the paid labor market. The employer may have some costs as well in terms of replacing you, which we call friction costs. There may be some insurance program costs as well, administration of workers' compensation that are internal to the employer's kind of administration process that have some cost to them. Ultimately, at the systems level, there's some productivity and output implications which continue on to the societal level. And then the quality of life is something that's really, really critical to include as well. Health-related quality of life captures a whole lot of things, including pain, suffering, and loss of enjoyment of life, but also the ability to engage in all kinds of social roles, whether it's leisure roles, community roles, a number of other things which we haven't captured explicitly in any of the other categories. So a really critical component. And for most of these cases, they have very short life expectancies after diagnosis. So the health-related quality of life component is usually the largest part of the losses at the individual level and at the societal level. And you'll see that in the computations on this table here. So health care, productivity, some friction costs, informal caregiving, but health-related quality of life, that last one, as you can see, if you look across here, it's more than half, 64% of the costs of a case are health-related quality of life cases. A lot of these people are past retirement when they manifest as having lung cancer, so the paid labor market activity is not a big loss for those kinds of cases that are into retirement. So that's the biggest loss, is like a shortened life expectancies. The total cost per case, this is in 2017 dollars, is $1 million across all of those three broad categories. Healthcare, most of it is palliative care for most of the cases. The survival rates are very low, unfortunately. So it's only like within a 1-year time period that there's some palliative care for most of the cases. Productivity losses for some of the cases that are dying prior to retirement age, but we also included home production, so the activity you do at home, we put a price tag on that as well. Are we all good with that? So we can accept this is something that's already been published in a piece that we did on asbestos-related lung cancer, and we've translated this now for silica dust and updated it to 2017 for the purpose of this study. Okay, so monetizing those benefits. So we take those yearly monetized benefits from the number of cases that are averted from our best practices intervention times the monetary cost per case. So that whatever number of cases we have times what the $1 million per case costing. What I showed you in the previous slide, the table was an average across a range of different age brackets at which lung cancer may manifest. But in our actual projections, we identify each sex, age group, and related costs separately. And also focused on occupational wage rates as well in the construction sector. So it got more granular, but I didn't want to get into too much detail in that summary slide. So estimating the intervention costs. Okay, next piece of the puzzle. Okay, so for the wet method. Okay, and a lot of this we're drawing on a really good study that was done by OSHA in the US. They did just a cross-sectional analysis using wet method and PPE. So we've projected it longitudinally for our purposes, because we're looking at a longer time frame kind of thing. But they've done some base level kind of estimates of what the costs would be, and we're drawing on some of their assumptions for these things. Some of them are questionable. We've struggled with what's realistic. First of all, we're assuming 62% of those people who are exposed could use the wet method. They're doing activities where that kind of equipment where you're wetting things down is feasible. The other 38% can't use it, so we're really focusing on a subset of the exposed group. We're assuming, and this is taken from that study, with that 44% of the people in the sector are already compliant with this method. That's something that's we're not sure about. It seems a bit high, I would say. That was from OSHA's assumption. We can play with that number a bit to see, what's the realistic assumption about what's currently happening out in the field and what level of activity is being undertaken with the wet method. So the incremental cost for doing the costing of this intervention includes equipment costs. So there's special equipment you need to buy in some cases. There's some operating costs involved in that equipment, ongoing maintenance of it. And then there's also what we describe as a productivity penalty, and that refers to the fact that oftentimes, whether it's this engineering control or even masks, it's harder to do your job, and so there's a little bit of loss of productivity while you're using that prevention method. So you're a bit maybe slower. Maybe there's some setup time involved that slows you down a bit at the front end, or cleanup afterwards that takes a bit of time. So there's a bit of a penalty productivity-wise for it, and that's part of the equation. Replacement period for the equipment, we assume, depending on what kind of equipment, there's a number of different kinds of activities and different kinds of equipment needed to be replaced between 1 and 10 years. Operating costs were about 10% of the capital costs. The annual maintenance cost of about 25%, so ongoing maintenance, repairs, that kind of thing. Productivity penalties range from between 0 and 5%. And so we estimate the total incremental cost using this method, assuming only 62% of those people exposed are using it in specific types of tasks over that 2030 to 2060 time period. This is for the personal protective equipment. In this case, anybody who's exposed can use it. So 100% of exposed workers are eligible to do it. And we're assuming that a little over half, 56%, are currently practicing that using a mask whenever they're doing that kind of activity. So we're only considering the remainder, 46%, of being incremental costs. So those costs are the mask, the filter, which need to be replaced quite regularly, some training time on how to use the mask well and fit it well, time for cleaning, time for fit testing, and then also a productivity penalty as well. And some details about that. I won't get into all those details. The average productivity penalty was about 2%. And then we estimated the cost for the entire exposed population over the 2030 to 2060 time period. And then there's some really high-level economic assumptions that we're making. These are only a handful of them, but the key ones. We used the wage rates from the construction sector and from the most recent labor force survey and projected them into the future. We actually assumed that productivity would increase in general in that sector by 1% a year, so wage rates went up to reflect that in that time period, not nominally, but in real terms, the productivity would go up and wage rates would go up. We assumed there's a fringe benefit of about 14% that people receive, and then that they work 220 days a year on average. And then all of the values we're looking at dollar-wise up to now and looking forward to have all been translated to 2017 calendar year dollars. So we've adjusted for inflation if we're looking at data that's from an earlier time period.
I had a question related to the previous slide. When you're talking about incremental costs,
Yes.
is that compared also, because there is a basic cost also even if you're using the dry method, right?
Yes.
So is it, so you would have to replace the training cost for the
Yes.
dry, yeah.
Okay,
So
that's a good point. Yeah. So I'll do all economics is generally done on incremental analysis. So you're doing something different, you're a new method. What are the additional costs you would incur relative to the status quo? So purchasing new equipment, training in a different method, activities are slightly compromised in terms of the productivity, all of the stuff that are extra over and above what you currently do.
I guess my question is, you calculate, and maybe I'm not clear in asking it, is like you have a certain presumed cost now, and you would have to subtract it out, I guess, in order. So let's say current equipment is $100,
Yes.
and you would have to buy
New,
100,
yeah.
200.
That would be more expensive. Yes, that's correct. You would need to subtract out, you know, how much more does that equipment cost relative to the equipment that's
Okay,
not,
that's what I wanted to.
you know, appropriate for the wet method. Exactly, yeah. So it's all just a marginal difference between the current practices. Yeah. Key evaluation. We're going to up the benefits in terms of averted cases and the costing of that, and then the cost of the actual intervention. So this is a break-even analysis using the wet method. So this is in millions of dollars. This is yearly cost. For the sector, the red line is the wet method. Increases. Full elimination dollars, so we can compare them, and they meet up in 2040 to 43, and after that the benefits, the monetized benefits exceed the cost because we're having a lot more averted cases. Remember, it takes long latencies, it takes a while before we really see a return in terms of reduced number of cases that happen mostly in the latter part of our 40-year time period. Just some background information. Remember we said percentage of exposed workers that use the wet method is 62%. So the current compliance level is 44%. And we're going to look at some other scenarios where we don't have full elimination. If we do 80% elimination, we have fewer averted cases, and so the break-even point is further down the road in 2044, 2045, if we only eliminate 80% of the cases. And if we eliminate 60% of the cases, you know, it's again further down, 2047, 2048. Sort of thing. So what we would expect to see, this goes back to your question about how effective the method is in terms of could we expect full elimination using that method, or it might actually be a combination. As we saw in one of the pictures, somebody was wearing a mask and using the exhausting system too. So maybe the wet method would work even better with a mask. We didn't look into those scenarios. That's something that is open for discussion about what realistic scenarios we'd expect to see with best practices with wet method being across the board.
So, sorry, no, I'm not quite understanding that. So when you're talking total elimination here,
Yes.
that is assuming that if everybody used the wet elimination method who could, and the wet elimination method was effective enough to eliminate all cases?
All exposure.
Okay.
Not all cases,
Sorry,
because some of the cases are from historical exposures.
Yes.
Yeah, exactly. Yeah, so if we can assume that the 62% of exposed workers who can use a wet method, and they all did, if we assume that all of the cases associated with those specific exposures during that time period were eliminated, we'd expect to see that red line in terms of monetized benefits.
Okay, so it's 100% elimination of the cases that currently we think are being caused by not using the wet method.
Something like that. I think you got it. The wording is it has to be really precise, but yeah, it's in that direction. Okay, so now we go for PPE, for the half mask. So the costs are higher on a yearly basis, $40 million. You see a little bit up and down because we're assuming that the masks last for 2 years, so you have to replace the mask every 2 years. So there's a little bit of up and down in the yearly costing based on that replacement time period. Full elimination. Now this is 100% of the people can use this method, and we're assuming that 56% already did, right, in the baseline, right? So if we fully eliminate exposures, we'd see this blue line here, and the cross points are in 2047. A little bit after what we saw for the wet method, not because it's necessarily less effective, but it's more expensive, right? So it takes more averted cases to break even. If we look at 80% elimination, it gets pushed out further to 2049, and then all the way to 2052 for if we only eliminated 60% of the cases.
This is taking the total cost, right?
On a yearly basis.
Yeah, right. And
Are you talking about employer benefits versus, not, rather than, our benefits here are averted cases, which are societal perspective on the costing of those cases. So we
Right.
think, well, what are the benefits exclusively for employers in terms of the cost, well, the costs are mostly borne by
Right.
employers,
So they're
and then the
very,
benefits would be a
informal.
subset of those things. No, we haven't. We could actually think about parsing out that bit of it too. We did want to take a societal perspective on this analysis, but certainly that employers are the ones who would be out for some of those costs in most cases. Unless there's some people may be self-employed contractors who bear the cost themselves, but by and large, the costing of the intervention is something you would expect employers would incur. Right?
Yeah, no, because one of the issues is that,
Yeah.
is for us to convince
Employers
employers
to do this. Yes. Yeah. The business case. Yeah, exactly.
There's one question of clarification about whether the costs were nominal or real.
Nominal or real? Well, the costs were real in an economic sense. We think about opportunity costs, right? So when I think about the cost of a case of lung cancer, the counterfactual that we look at is you would have lived a normal life expectancy. We look at the average life expectancies and the health profiles of the average Canadians, sex and age adjusted, and then the average wage rates and earnings that people would have if they lived a full life and retired when most other people do. So it's a counterfactual that doesn't exist. It's the other road we could have taken, the high road, I guess. So in that sense, it's not something that you can put your a pin on directly, other than by thinking about, well, what's that alternative scenario would look like if we didn't have cases of lung cancer? What would their lives be like? And that's where we frame that around a standard life expectancy and standard activity levels in the labor market. So it's an opportunity cost, so that is foregone because of BVN case. Does that help? Okay.
I'm sure.
Okay, so here we have, we're just putting the two now back to back, the wet method and the PPE, and we've changed all the costing on a per exposed person costing level. So the per person on a yearly basis for the wet method is about $200. It's about $400 for the PPE, and then the blue lines are the full elimination on a per exposed person basis, right? So really looking at the break-even point, you're going to be at the same part, but just bringing it down to on a per person cost. So that might be a good starting point for employers to think about on a yearly cost for a worker of these methods: $200 incremental cost and $400 for the masks. So just a summary here of what we found. So in terms of our break-even analysis for the wet method, full elimination, we break even at 2043 for the masks, 2047 a little bit later. The total cost, it's a range because the break-even point happens in mid-year, so we're trying to fine-tune exactly 6 months or 8 months wasn't exact, and so the costs were between $16 and $18 million at that point, and for the masks it was $43 to $47 million. Higher because the per person costs are higher, so we have to wait longer to break even. And that's the number of averted cases: 15 for the wet method, 27 at that break-even point. So just some summary and discussion items. Good timing. Okay, so due to the long latency between exposure and manifestation of lung cancer, it takes quite a few years, as I pointed out, before the averted cost can be realized from the averted cases, and the related costs can be realized to be sufficiently large in terms of be equal to the intervention costs. And just the summary of the wet method and the PPE. The costs, are quite high, but we do break even before our 2060 time period, and from that break-even point onward, the benefits exceed the costs. So we haven't done a scenario where we summed it up to present. Some of these scenarios, they aggregate all of those costs over the 40 years, and we'll look at them as a whole package. But we haven't done that because the curve that we're projecting of averted cases continues to rise, and I'm not sure, we haven't done projections beyond 2060 to see where it plateaus in terms of the maximum number of averted cases, and that would be an interesting thing to do down the road to get a sense of when that maximum of averted cases on a yearly basis would be realized. It's difficult to compare the two methods because the number of workers who are covered by them are different. Additionally, the baseline compliance has been assumed to be different in our scenarios, 44 for one and 56 for the other. I'm not sure if that's realistic for the Ontario construction sector. As I said, we took that from OSHA. OSHA had done a lot of consultations in the U.S. around their design of their study, so I'm assuming that they found that to be realistic assumptions for the construction sector in the U.S. Per covered worker costs are comparable, so $200 versus $400 in that range in terms of wet and personal protective equipment approach. What exposure reduction can be assumed with each of these methods? Back to your question. I'm not 100% sure, and this is something we're struggling with. We do have the background from the literature, but what exactly to expect in terms of would there be some residual exposure even after using the mask? I'm not sure. That requires, I imagine, some kind of field work to really drill down on exactly whether that does fully eliminate or not, or whether it needs to be some combination of approaches like mask and wet method together. I think some of our estimates are conservative. We didn't really consider any other kinds of diseases. If you're wearing masks, obviously it eliminates a lot of other types of exposures as well. So there are other diseases, maybe related to silica dust, but other types of carcinogens that you'd be eliminating by using the mask. So I think the costing of the averted cases is a bit on the conservative side. We also didn't consider, as I mentioned, local exhaust and some combination methods, and that might be one of the best practices that down the road might be more realistic for at least complete elimination, thinking about mask and wet method together, or local exhaust and mask together. So a lot of pieces, so hopefully more of them have fitted together nicely, maybe not all of them. Well, I've left one out of place here, but certainly there is work to be done in terms of finessing some of those assumptions, making them more realistic for what we actually see in construction, and filling in some of the unknowns in terms of what we'd expect to see in terms of reductions and exposures with these best practices. So questions or insights?
Thank you. I'm always fascinated by the construction of models.
You like puzzles?
We used to predict things. From this, well, this may be a really stupid question, because I'm fascinated, but I don't really understand. Maybe that's why I'm fascinated. Do we know, would it be possible from this analysis, from this work, to know what the relationship is between the growth of the economic sector and the break-even point? I mean, how does the break-even point move, and how much does it move with an increase or a decrease? So let's say the projected increase of the construction labor force was, instead of, you said 25%.
Yeah.
If it was 40,
yeah.
How would that affect the break-even point? Presumably, I mean, the health benefits, the benefits would increase because more cases would be prevented, but presumably also the implementation costs.
Yes. That's a good question.
Do you know how much it moves?
We didn't do any sensitivity analysis yet around those growth projections kind of thing, but the cost of the activity would go up too, because we costed out ultimately down a per person basis, particularly for the masks. That's an individual level cost. The wet method, sometimes it affects a group of activities, like where several people are involved, but we try to translate that into individual costs. So the per case cost would go up with the number of cases that are exposed. So I'm guessing that we might not see too much of a difference, but we haven't done a sensitivity analysis to really test that out. So that's a good thing to really consider.
Peter.
Emil, I guess more of a philosophical question. Why do we need a break-even point? Like, if we know that there's a substance that causes disease and death, we know there's a method that could potentially reduce that. But we don't complain about paying for the incremental costs of putting seatbelts in our cars. Why do we need a break-even point?
Okay, so you're not asking about why do the economic analysis, but why frame it around a break-even point.
Why is that important to economists?
Okay, well, not to economists, hopefully to you too, but and other people. I mean, the costing that we put into all of this costing that we put into the averted cases is a reflection of what we're trying to capture is societal values, right? So you might look at willingness to pay values for measuring health-related quality of life. We didn't. We used $100,000 per quality, which I think willingness to pay values. I'm not sure if people know that terminology, willingness to pay. You can actually ask people how much are they willing to pay to avert, these exposures and improve their life expectancy and their quality of life by not, reducing their probability of getting lung cancer. So we did build into it the values of health-related quality of life, not through the willingness to pay metric, but through just a policy value that's been used in the literature. Even if we substituted, at the end of the day, we come up with a price tag for averting a case that are societally defined values, right? And so any kinds of assessment of resource implications, you want to think about how much is society willing to pay for those benefits and how much does it cost to realize those benefits. So they should, both sides of that equation should reflect societal values. Now, mind you, it's only one piece of information. It's not, there's other reasons why we go forward with different initiatives, even if it may not be the most cost-effective kind of alternative. There might be precedents or other just policy decision-making processes that put other things into the equation. But we are trying to reflect societal level values in both sides. The pricing mechanisms, hopefully in the market, reflect what people are willing to pay for goods and services and masks or whatever it is that in the costing side, on the benefit side. So I think we are just starting with the point, well, where do we realize an equality of the willingness to pay for those averted cases versus the costs that we incur? And beyond that, we would definitely want to go forward with it because the net benefit exceeds the costs. So it's really built into the economic analysis of thinking what people value in society and what's important to them.
Okay, wait, sorry. I've got a list. If you don't mind, I've got someone on the webinar, and then you, and then Monica and Curtis. If that's all right? Thanks.
One quick question and then another question. Were the limitations of respirators considered?
The limit, and what kinds of limitations?
Well, there might be gaps in the respirator, or they might have old filters.
Okay, so good question. We did put into the equation the cost of getting training around fit testing, right? So training and fit testing, and that's really important that it fits well, kind of thing, and maybe different people may choose different types of masks depending on their facial features and stuff like that. So that was an important part of the costing side of it, and the filters were assumed to be having to replace on a periodic basis. I don't know the specific details, but we did take into consideration what the prescribed replacement rate for the filters were as well. So we did try to think about, what are the best practices to make them work the best, and what are the costs involved in that.
So there was another question/concern about the consideration of combined methods, so wet method with masks, and that the person feels that you should consider those two somehow, make the modeling with both of those.
And that's a very good suggestion, and not too hard to do because we have the costing. We can just add them together, right, and put the two together and say, well, $400 plus $200, $600 per person, and think about where the break-even point would be from that scenario.
Sorry for
Thank you.
Go ahead.
Yeah, I guess I'm trying to see whether you have taken into consideration current regulatory requirements now, because it could be theoretical whether it's the wet method or not. If we have an occupational exposure limit and we specify what should be used as protective measures, so has that analysis compared the current situation of what our legal requirements are?
Good question. We not explicitly we take into consider regulatory requirements in that I'm assuming that the using the masks with the proper fit testing and all that exceeds the regulatory requirements, and the wet method does, or at least meets them, kind of thing. We are assuming improvements in current practices is the main thing that we're focusing on, because it's not used across the board. But how well it adheres to the accepted maximum exposure levels, I think we would need to know how effective they are in terms of elimination of those exposures, which is something we started talking about earlier on, which I'm not too familiar with, whether it results in 100% elimination or not.
Yeah, I think that would be important to look at, because if there's already regulatory requirements, and I don't know the specifics now, can't remember them, what is it that analysis adds over what we have currently in place? Yeah.
Oh, good question. I think it adds the fact that people aren't doing it and how much would it cost.
And that's a different issue. The question is,
Yeah.
why are they not doing it, and how can we get them to do it?
Yeah, exactly. Yeah. Good point.
So I don't think we have time for everybody's questions, but maybe Monica, final quick question?
Sure, and partly because I think it relates to Molly's question maybe. In the two graphs that you showed, the increase in the number of projected cases was about a 25% increase over the time
Yes.
period. The increase in the next slide, sorry, that was the number of workers, was about a 25% increase. The number of cases, it was a 75% increase over the same time period.
Yeah.
And I'm wondering why that doesn't seem to increase the same way. So the previous slide, the one right before this, is the number of workers exposed, which goes the same way, and then this one is not. So I don't, if that presumably is partly the lag period.
Yeah, I'm guessing that there's a lot that goes into these projections, but there is a whole period of exposure prior to 2030. In fact, our intervention technically starts at 2020 to reduce exposures up until 2050 in terms of the intervention costing. But before that, there's exposures as well, and I think that result in cases even when we completely eliminate.
Right.
So there are, for that reason, as well as the growth in the sector that's been happening, even growth prior to this time period, that results in the growth in the number of cases.
And I guess I'm just wondering if that might be part of Wally's question as well, in terms of the
Yeah, and then there's the demographics are built into this model too, like the age distributions that we see currently versus what we'd expect to see in the future. So there's lots of variables that build on, if the population is aging, that there'll be more cases being realized as well.
Thank
That is the last question.
Is your question quick, Curtis?
Well,
Maybe.
Whatever time you have to answer artificial intelligence and robots, I was thinking if they can put together an autonomous driving vehicle, they may well be able to come up with a robot that does this, and that would affect the labor market, how many people are exposed, and then the hierarchy of controls that would be. And so, is that somehow factored in?
No.
Quick question. All right.
That's his next economic evaluation.
That I went to a car manufacturing plant, and it's amazing the robots that they have now. You could estimate, maybe based on what happened in the car manufacturing industry, how many people might be out of job.
Good point. That would be a tough one for us to build into our modeling, but we'll think about it.
Thank you very much, Emil.